Hello, everyone, and welcome to our program. Today, the Zoom meeting. We'll have a very busy, hopefully, meeting. So here's the agenda, and Dr. Flut is going to lead the meeting. I'll turn it to you, Dr. Flut. Thank you.
Okay, thank you, Dr. Nasr. Okay. Hello, everyone, and hope you are all doing great. This is Orange team. My name is Khulud Ahmed. Today we are presenting the meeting agenda for this Saturday, is October 2nd, 2022. And we will start with our agenda. We have prostate disease and cancer will be presented with Dr. Duaa Nasereldin and Dr. Nafisa and Dr. Mounika. So Dr. Duaa Nasereldin, if you are available here, you can start. Sure.
Hello, everyone. I hope you can see my screen now.
Yes, you can see it. Go ahead.
Perfect. So good afternoon. My name is Duaa Nasereldin. I'll be presenting today with my colleagues, prostate disease and cancers. The objective of our webinar today is to establish or to figure out how to establish a diagnosis of benign prostatic hyperplasia and the lifestyle modification pharmacological therapy used and surgical treatment option for BBH. Also, what to tell healthy men about prostatic or prostate-specific antigen screening for prostate cancer, as well as which patients with prostate cancer are candidates for watchful waiting and how to recognize and treat prostatitis. So the topics will be covered are benign prostatic hyperplasia and prostate cancer, as well as prostatitis. Overview of prostate disease. We have benign prostatic hyperplasia, which develops in over half of men more than the age of 65 years, and an overwhelming majority of men about after the age of 85 years. Prostate cancer is the second leading cause of cancer death in men, but many patients have asymptomatic or low-grade tumors. And the prevalence of prostatitis is similar to that of ischemic heart disease or diabetes mellitus. So BBH is a non-cancerous enlargement of the epithelial and fibromuscular component of the prostate gland. And microscopic BBH is present in 50% of men by the age of 60, as you can see in the diagram. And also about 90% of men by the age of 85. So half of men with microscopic BBH develop or go on to develop palpable macroscopic BBH, which half of those are clinically significant disease brought to medical attention. So prostatism, which is lower urinary tract symptoms, we have irritative and obstructive. Irritative, which is frequency, urgency, and nocturia, and obstructive are hesitancy, intermittency, and weak stream, incomplete emptying as well. The International Prostate Symptom Score, which is quantitative index developed by the American Urological Association for assessing the symptom severity and monitoring the treatment response, is adopted by World Health Organization and is used as a symptom severity for long-term patients management. but has not been found to correlate with prostate size, urine flow rate, or post-void residual volume. So diagnosis of lower urinary tract symptoms, we use digital rectal examination, may be unremarkable or reveal an enlarged, smooth, rubbery, and symmetric gland. We also can do urinalysis, which is a routinely performed to evaluate for UTI, hematuria, and glycosuria. Additional subsequent tests include post-void residual urine volume, often done by office or bedside bladder scan, and urine flow rates and pressure flow studies. These are considered when the diagnosis is uncertain or an invasive treatment is being planned. So Bbh treatment approaches. It depends on the patient and is driven by the impact of symptoms on the patient's quality of life. We can do either medical and surgical intervention, but we start out where the first approach is always medical. The indication for the surgical approach are patient preference or dissatisfaction with the medication, and refractory urinary retention and renal dysfunction, bladder stones, recurrent UTIs, hematuria, if these are clearly due to prostatic obstruction. We have the lifestyle management of Bbh. The interventions are to reduce the nighttime fluid, to manage the nocturia, or eliminate the bladder irritants such as nicotine, caffeine, and alcohol. Also avoid drugs, especially anticholinergics that aggravate the symptoms. And those are often used in treating sufficient treatment or management for mild symptoms, but also a component or complement in the treatment of moderate to severe symptoms. We have the alpha-adrenergic antagonists for Bbh, which are alpha-1. They act on the smooth muscles of the prostate tissue and capsule and bladder neck, and they lead to decrease in resistance to urinary flow. Alpha-1 are mainly prazosin, and we have the long-acting, which is the selective for alpha-1, which is prazosin and doxazosine. We have also the slow-release, long-acting, selective for alpha-1, which is tamsulosin and telodosine and alfuzosin. The adverse effects are dizziness, mild asthenia, and headaches, postural hypotension, and also we have abnormal ejaculation and rhinitis. We use it with caution for patients who are undergoing cataract surgery and intraoperative floppy iris syndrome, especially tamsulosin. They have highest or greatest frequency and severity in developing in those with intraoperative iris, floppy iris syndrome. We also can use the second line, which is 5-alpha reductase inhibitors, such as finasteride and dutasteride, which is used to reduce the tissue levels of dihydrotestosterone. It results in prostate gland size reduction, and therefore is most effective in men with higher or larger prostate, more than 40 grams. It leads to improvement in symptom, and urine flow rate may not be evident for up to 6 months in this case. Anticholinergic medication for Bbh. Anticholinergic agents, the role are in management lower urinary tract storage symptoms in men with Bbh, and they're used alone or in combination with the alpha blockers, and they do not seem to significantly increase the post-void residual urine volumes or provoke the acute urinary retention. We have also the phosphodiesterase 5 inhibitors, which is tadalafil. They usually work on the bladder neck and prostatic urethra and prostate musculature. They contribute to urinary symptoms. They're effective for men with or without the erectile dysfunction. The only drug that can be, they treat both the BBH and ejaculatory dysfunction in this case. Also, we use it with caution when using it with alpha blockers due to the similar adverse effect of hypotension. We have also the surgical intervention, which is transurethral resection of the prostate or open prostatectomy and transurethral vaporization of the prostate, transurethral incision of the prostate, and stent placement. And the mechanism is removal or expansion of the periurethral prostate tissue, and that will reduce the obstruction to urinary flow. Indications are recurrent urinary tract infections induced by the benign prostatic hypertrophy. Also, the recurrent or persistent growth hematuria and bladder stones and renal insufficiency. They have higher adverse effect. So the management of acute urinary retention, which is sudden and painful inability to pass the urine, is considered a urinary emergency and occurs in up to third of men undergoing TURP, and may be the result of natural progression of BBH, or it may be precipitated by surgical procedure, infection, and medications. They're considered immediate management is considered by bladder decompression, and it's usually done with urethral catheter insertion. So prostate cancer is most common non-cutaneous cancer among men in the United States, and we mentioned before that it was the second leading cause of cancer death among the men in the United States. Incidence increased with the age, and it's rare in men less than 40. Incidence, it varies according to the race, but it's most common among the Black Americans or African Americans, having the highest risk in the world or globally. So among the Black American men, prostate cancer occurs at an earlier age, and they have a higher mortality rate and tends to be at a more advanced stage of disease at diagnosis period. We have also the family history, which is a contributing factor. Men with one first-degree relative having the condition are 2 times higher risk than those who don't have a family history. And also there is a history of sexual transmitted infection that can also be associated with increased risk. In this diagram, this is based off of a prevalence study conducted in 2008, and it shows it's conducted on 230 healthy individual men. Prostate cancer was indicated at autopsy, and there was about 23% of men at the age of 50 to 59 years who are found to have prostate cancer. And also 80% among those who are 80 or more years of age were found to have prostate cancer. So by this time, I'll give the opportunity to my colleague, Nafisa Mustafa, to conduct the second portion of this presentation.
Thank you, Dr. Doaa. Good afternoon, Dr. Nadir. Good afternoon, everyone. Are you guys able to hear me well?
Yes, Nafisa, go ahead. Can start now.
Thank you. Yeah. All right. Okay, so I'll talk about the symptoms of prostate cancer. So most patients, especially those with early stage potentially curable disease, are asymptomatic. And the symptoms when it happens, and that can due to either direct invasion of the urethra and bladder, can lead to irritative voiding symptoms, urinary incontinence, as well as hematuria. Also can be due to extension of the disease to adjacent nerves, may cause impotence and pelvic pain. Nodal metastasis can cause extrinsic urethral obstruction, and that can come with urinary retention. Lymphatic obstruction may result in leg edema. Hematogenous metastasis to bone may cause severe leg pain, normochromic normocytic anemia, pathologic fracture, spinal cord compression. Less commonly, hematogenous metastasis involve the lung, liver, and adrenal glands. Prostate cancer screening controversial. So the benefit of early detection and the best approach to treatment of prostate cancer are controversial. It's very important to understand that most men with prostate cancer die with the disease, not from it. So guidelines agree that the controversy about screening should be discussed with patients using a shared decision-making approach. Digital rectal exam that allow palpation of the posterior surface of the lateral lobe where cancer most often begins, can often detect local extension of prostate cancer into seminal vesicles. Part of the prostate gland cannot be reached. About half of cancer thought to be confined to the prostate on the basis of the digital rectal exam are found during surgery to have spread. Biopsy confirms cancer in only about 1/3 of positive digital rectal exam find. Serum PSA test. It's not specific for prostate cancer. PSA elevation occurred in benign condition of the prostate, example, benign prostatic hyperplasia, as well as that other factor can increase the PSA level, example, after digital rectal exam, after ejaculation, that also can increase the level. False negative rate, it's 30 to 40%, and positive predictive values about 28 to 35%. Novel measurements may improve accuracy. So PSA density, PSA rate of change or velocity, age adjusted PSA reference range, and ratio of free to complex PSA. Biopsy for diagnosis of prostate cancer. Abnormal digital rectal exam or PSA test suggests the need for transrectal ultrasound guided biopsy of the prostate. Spring-loaded core needle biopsies were routinely taken from the base, middle, and the apex of each loop. 6 samples total and 16 biopsies. Extended biopsy schemes 10 to 12 cores with more apical and lateral sampling increase cancer detection rates. Biopsies may be taken from suspicious area on imaging, either from ultrasound or MRI, in addition to palpable nodules. Gleason grading system for prostate cancer. Gleason grade range from 1, which is considered well differentiated, to 5, and which is poorly differentiated. Gleason score, it's a sum of the most common Gleason grade seen plus the next most common Gleason grade seen, and that range from 2 to 10. The scores are sometimes grouped as 2 to 4, which is considered well differentiated, and that's a favorable prognosis. 5 to 7, that's moderately differentiated. 8 to 10, it's poorly differentiated and is unfavorable prognosis. WHO grade groups for prostate cancer. Grade group 1, which is Gleason score equal to 6 or less. Grade group 2, which is Gleason score 3 plus 4, that's the adjacent Gleason score, equal to 7. As we mentioned, it's the sum of them. Grade group 3, which is Gleason score 4 plus 3 equals 7. Grade group 4, which is Gleason score 8, and grade group 5, Gleason score 9 and 10. Staging of prostate cancer. In staging, we have the TNM staging system, which is T stand for tumor, N for nodal, and M for lymph node involvement, and M for metastasis. Jewett-Whitmore stage, and that's also include A, B, C, and D. A for subclinical tumor, B for palpable tumor, C for extracapsular extension, and D for metastasis. So when the TNM stage T1, that's Whitmore stage A1, A2, means that tumor is an incidental finding. T1C, C for core, that tumor is identified by needle biopsy as follow-up to screening that detect increased PSA level. T2, P1, P2, that's the tumor is palpable, confined to the prostate. T3, TNN stage, that's equal to C1 to C2, which is tumor extend beyond the prostate capsule and may involve seminal vesicles. T4, C2, tumor invade adjacent structure, example bladder, neck, rectum, and pelvic wall. N or D1, that can which is lymph node metastasis present, and in metastasis D2, which is distant metastasis present. Okay, thank you. And leave the mic for my colleague, Dr. Mounika.
Hello. So should I share my screen?
Yes. Thank you, everyone.
Thank you, Dr. Nafisa.
So hello, everyone. So we'll be, till now, we just read about what are the symptoms of prostate cancer and staging of prostate cancer. Now we will see when we should order a bone scan, or when should we do the active surveillance, and based on these Gleason scores. And we will also talk about what are the procedures that will prolong the life to improve the quality of life. So here, initial evaluation. First, we will always start with the PSA level and DRE findings, transrectal ultrasonography results, and Gleason score, and then bone scans on patients with bone pain or PSA values more than 10. So we should be important that PSA value should be more than 10 to order a bone scan, and then multi-parametric MRI where resources or expertise available. So for patients electing active treatment, so we will do the surgical assessment of lymph node involvement and prostate surgery or implantation of the radioactive seeds. And CT is often employed. So we will categorize the patients into very low risk, intermediate risk, and high risk based on the criteria. So this is for the localized prostate cancer, risk stratification and treatment recommendations. So very low risk, that means the PSA level will be less than 10. So I will just summarize very low risk and low risk. Both are almost same, like PSA level less than 10. Grade group is 1. And here the clinical stage is T1 and T2A. And less than 34% of the biopsy codes positive, and no core with more than 50% involved, and PSA density less than 0.15. So we are considering the PSA biopsy and also the PSA density here. And recommended treatment is active surveillance. So very low risk patients, we do active surveillance. And low risk patients, again, PSA level less than 10, grade group 1, and clinical stage T1 to T2A. They also recommended treatment is active surveillance, SOE-B, that is standard of evidence, that is B, and definitive treatment for selective patients, SOE-B. And then here is the intermediate risk and high risk. So we have to know when the patient is transitioning from intermediate to high risk. So intermediate risk is PSA levels 10 to 20, and grade group 2 to 3, and clinical stage T2, 2B to 2C. Favorable and unfavorable conditions here. So the patient is in grade group 1 and PSA level 10 to 20, or grade group 2 with PSA level less than 10. And unfavorable, grade group 2 with either PSA 10 to less than 20, or clinical stage T2B to C, or grade group 3 with PSA level less than 20. So when we have intermediate risk, the treatment recommended is radical prostatectomy or radiation therapy with ADT. So they fall under SOEA. And then favorable conditions, active surveillance possible, comes with with higher risk of metastasis. So we have to make sure the patient is intermediate risk, and we have to do the recommended treatment, radical prostatectomy or radiation. And if the patient is in high risk is PSA more than 20 and grade group falling 4 to 5. So we should definitely do the radical prostatectomy or radiation therapy with ADT. Now, management of localized prostate cancer. So we should be careful when should we do watchful waiting or when should we do the active surveillance. So watchful waiting, prostate cancer is not treated until symptoms develop. Offered to men with less than 10 years life expectancy, significant medical comorbidities, small, well-differentiated tumors, or unwillingness to bear treatment burdens. But awaiting symptom sacrifices opportunity for cure. So this is the con for it. And active surveillance, prostate cancer treatment is delayed until evidence of disease progression. So offered to men with cancer detected by PSA screening and Gleason score less than 7 and small volume involvement. So this important active surveillance less than Gleason score less than 7. Radical prostatectomy, surgical removal of the entire prostate and gland and seminal vesicles. So radical is something like we remove the entire gland and also seminal vesicles. Offered to men with absence of surgical contraindications and adverse effects realized immediately. And then we also have external beam radiation therapy and brachytherapy. So external beam radiation therapy is standard regimen, which delivers 6,000 to 7,000 rads of pelvic radiation. It's done over 5 to 8 weeks period. So this radiation reaches tissues outside the prostate, including the pelvic lymph nodes. So adverse effects occur initially from radiation-induced inflammation and then develop over time as the scar tissue develops. Then we have brachytherapy. Radioactive seeds, example, iridium or palladium, are implanted into the prostate gland using computerized CT scan guided guidance. Here we'll see improvement in the prostate imaging, allow uniform distribution of seed, overcoming past limitations. So adverse effects occur initially from radiation-induced inflammation and then develop over time as scar tissue develops. So management of locally advanced prostate cancer. So radiation therapy is a recommended treatment. Neoadjuvant androgen deprivation increases the chance of survival and freedom from metastasis. So if we do the neoadjuvant androgen deprivation, so that will increase the chance of survival. And then timing of androgen deprivation is controversial. So if the patients may have prolonged asymptomatic period here, and long-term androgen deprivation can have substantial negative effects on quality of life, including loss of stamina, increased fatigue, hot flashes, diminished muscle mass, and premature osteoporosis. So that's why the patient should be given the choice of early versus delayed androgen deprivation because of these side effects. Then we have androgen ablation for advanced prostate cancer. Orchiectomy and LH-RH agonists are equally effective at reducing androgens to castration levels. So both are equally effective. So LH-RH agonists like leuprolide and gasorelin produce castration levels about a month after initial increase in serum testosterone levels. So first they will increase in 1 month and then they do the castration. Anti-androgens like frutamide are often given before LH-RH agonists to blunt the effects of testosterone increase. Complete androgen ablation, adding chemical or surgical castration to anti-androgens slightly improves the survival. So adding complete androgen ablation slightly improves the survival. And then we have chemotherapy for advanced prostate cancer. In men with metastatic hormone-sensitive cancer, docetaxel is a drug which delays disease progression and also enhances overall survival. This is only for the hormone-sensitive cancer. And then we have radiation therapy for advanced prostate cancer. It is useful for relieving the pain of isolated bone metastasis and reducing the risk of fracture. If we have diffuse bone metastasis, requires alternative approaches like bone-seeking radiopharmaceuticals such as strontium or radium can be beneficial for pain control. Androgen deprivation and bisphosphonates can decrease bone pain. So that concludes the management of prostate cancer. And then we are moving on to prostatitis. So here we'll start with the etiology. May have acute bacterial, chronic bacterial, or non-bacterial causes. The source of infection most commonly is ascending urethral infection and or reflux of infected urine into the prostatic ducts. Direct extension or lymphatic spread from the rectum is also possible cause, and then hematogenous spread. More than 80% of patients with prostatitis have no identifiable infectious agent. Diagnosis of acute bacterial prostatitis. So we'll look at the symptoms. If the patient has fever, chills, dysuria, tense or boggy, extremely tender prostate, then it is acute bacterial prostatitis. So bacteremia may result from manipulation of the inflamed gland, while minimal rectal examination is indicated. So it should be very minimal. And then gram stain and culture of the urine can identify the causative agent. And then diagnosis of chronic bacterial prostatitis, marked by varying degrees of perineal pain and obstructive and irritative voiding symptoms. So when it becomes chronic, we will have on and off perineal pain, obstructive and irritative voiding symptoms. So prostate often feels normal. So we'll compare first void or midstream urine with expressed prostatic secretion or urine collected post-massage. Expressed sample should reveal leukocytosis and the causative agent. We'll look for both. And then sterile expressant with leukocytosis suggests non-bacterial prostatitis. Then we have treatment of acute bacterial prostatitis. Antibiotics may require hospitalization. So severe inflammation allows antibiotics to penetrate the prostate. Initial antibiotic selection is based on urine gram stain results with subsequent consideration of sensitivity profiles. And then we'll start with the fluoroquinolones. Fluoroquinolones are the highly effective in most cases. Prompt response to empiric therapy is expected, only in the case of acute bacterial prostatitis. If recovery is delayed, then we will consider CT or MRI to evaluate for an abscess. Then we'll go to the chronic bacterial prostatitis treatment. Here, antibiotics are less effective because of poor penetration of the prostate by most of these drugs. 6 to 16 weeks of therapy offers a cure rate of only 30 to 40%. Continuous low dose antibiotic suppression therapy can be offered to patients with frequent symptomatic relapse. Total prostatectomy offers cure, but has a high risk to benefit ratio. Transurethral resection of prostate is safer, but cures only 1/3 of the patients. Okay. And then we have treatment of non-bacterial prostatitis. So there is no bacteria here, so we'll be treating symptoms. So treated symptomatically. A small percentage of cases involve occult infections. So in those cases, we'll do empiric antibiotic therapy is often used. To reduce pain and discomfort, anti-inflammatory agents, sitz bath, fluid adjustments, we should avoid caffeine. And then we will start the patient on anticholinergic agents and alpha-adrenergic antagonists. So choosing wisely. So that means that these are the recommendations based on American Board of Internal Medicine Foundation's Choosing Wisely campaign. So do not perform PET scan, CT scan, or radionuclide bone scan in the staging of early prostate cancer at low risk of metastasis. A routine bone scan is unnecessary in men with low risk prostate cancer. Do not order creatinine or upper tract imaging for patients with BPH. Do not treat and increased PSA with antibiotics for patients not experiencing other symptoms. So we have to make sure we follow all these. And then this is the summary. So treatment options for BPH include watchful waiting, drug therapies, minimal invasive procedures, and more extensive surgery. The choice of BPH treatment is influenced by extent of symptoms and the presence of complications from outflow obstruction and patient preference. The use of 5-alpha reductase inhibitors for BPH is especially indicated when the prostate gland is large. The patient should be informed that recommendations regarding screening for prostate cancer using PSA differ among experts. The decision to screen a patient for prostate cancer should be made using a shared decision-making approach. Then treatment options for localized prostate cancer include watchful waiting, active surveillance, resection of the gland and seminal vesicles, and radiation therapy. This is for the localized prostate cancer. And how the patient balances the potential benefits and burdens of the various options will influence the choice of therapy. For patients with chronic prostatitis, effort should be made to identify the causative organism. Even with prolonged course of appropriate antibiotics, the cure of chronic prostatitis can be expected in fewer than half of patients. And then we have 3 cases here. A 65-year-old man comes to the office because he has a frequent and urgent need to urinate. His symptoms have slowly worsened over the past year. No history of gross hematuria, acute urinary retention, or UTI. No family history of prostate cancer. International prostate symptom score. Total symptom score is 6 with a border score of 1. Okay. Examination, the phallus is circumcised. Bladder is not palpable and there is no suprapubic tenderness. Rectal findings indicate a slightly enlarged prostate gland without nodules or tenderness. So laboratory findings, the PSA level is 1.3 nanogram per ml. Urinalysis, no blood, no microscopic blood, no leukocyte esterase or nitrates. Which of the following is the best next step in the management? Lifestyle modifications, cystoscopy, start tamsulosin, start finasteride. So here,
lifestyle modification.
Lifestyle modification, yes. So we will always do the lifestyle modification and watchful waiting first rather than doing anything else. And then the second question, 70-year-old man comes to the office because he has a frequent and urgent need to urinate. He reports no other problems, no history of urinary retention or UTI. He drinks 1 cup of coffee in the morning and diet soda throughout the day. His bowel movements are irregular. He has not noticed any blood in his stool. International prostate symptom score, mild voiding symptoms with low impact on quality of life. History, hypertension, atherosclerotic heart disease, mild BPH, and osteoarthritis. Medications he's taking are tamsulosin, aspirin, metoprolol, hydrochlorothiazide, occasional acetaminophen for joint pain. On review of systems, he notes that his vision has worsened, especially in his right eye. His ophthalmologist has recommended cataract surgery. So examination, there is cataract in the right eye. Cardiopulmonary findings are normal. The abdomen is soft. Phallus is circumcised. Testicles are bilateral descended with no masses. Prostate gland is normal on rectal examination. So lab findings, PSA is 1 nanogram per ml. Urinalysis, no blood, no leukocytes, or no nitrates. So in addition to aspirin, which of the following medications requires adjustment before the cataract surgery?
Tamsulosin.
Yeah, because tamsulosin causes floppy iris syndrome. So we should be careful with the tamsulosin. So the last question, 67-year-old man comes to the office to discuss management options related to prostate cancer. He had a PSA level of 5.2 and underwent transrectal ultrasound guided by prostate biopsy. Gleason score is 3+3 is 6 in 2 of 12 cores, involving 30% of each core. He wishes to undergo watchful waiting or active surveillance. On distal rectal examination, the prostate is enlarged, smooth, and anodular. Which of the following is the best next step for this patient? Repeat PSA and biopsy to confirm pathology findings. Repeat PSA in 6 months and biopsy in 1 year. Order abdominal and pelvic CT and bone scan to stage disease. Explain that he is not a candidate for active surveillance. Anybody wants to answer this question?
I think it is D. He's not a candidate for active surveillance.
No, I will go with the repeat PSA in 6 months and biopsy in 1 year, probably. Let's take a quick look at this question again. So PSA level is 5.2, Gleason score is 6, and he wishes to wait or do the active surveillance. Okay. Yeah, so we will repeat the PSA in 6 months and biopsy in 1 year. So we are doing the active surveillance in this case. Thank you for everyone who is editing the slides and giving this opportunity to me.
Thank you so much. Great presentation. Thank you so much, Doctor. Now, if there is any question about the prostate disease and cancer. I'm not seeing anything in the chat, so we can go for the next agenda for today. We'll go with the third one, and we'll respond one for the maybe later. So we'll go with LinkedIn. How can I shine there? It will be presented with Dr. Noura Mohyedeen and Dr. Doaa Mohammed. Dr. Noura, if you are here, you can start.
Yes, hi everyone.
Yes.
Okay, can you see my screen?
Not yet, Noura.
Yes, no?
Now, yes, you can see it.
Okay. Hi everyone, my name is Noura. I'm going to talk today about branding yourself online. Even if you are a private person, using LinkedIn is crucial in this new era. Why? Because 80% of the employer use LinkedIn as recruitment tool. So let's give you a few tips to help you to brand yourself effectively. First, in order to use LinkedIn effectively, you have to ask yourself 4 questions. What is your goal? What position you are looking for? The more specific you are, the more benefit you will get. For instance, everyone right now looking for a specific residency program at a specific hospital that he applied to. To that extent, you want to be specific. Second, how you define yourself. For instance, I'm an MD, I'm a clinical researcher. Next one is ask yourself what network I have, what current job you do, what medical school you went to. The last one, what network you would like to have. So by answering these 4 questions, you're going to create a map, a plan in your head. So let's give you tips how to use LinkedIn profile. First one, optimize your profile. This point means your goal has to be all-style profile. What does that mean? You see, every entry you enter in LinkedIn, it gives you 1 point. So you have to get 7 points. So for instance, if you enter your experience, this 1 point. If you enter your education, 2nd point. So you have to create 7 out of 7. Okay. Second is creating a headline. It's simply answering the question who you are. I'm a physician. I'm a match applicant 23. I'm MCPG 35, like that. Next is crafting a summary. The summary should be including your passion, your work, and your actions. The easiest way to think about that is to ask yourself, you know, when you in an interview, they ask you, tell me about yourself. You know, this answer for this question is the summary. So think about it like that. Next, at LinkedIn other profile. If you have Twitter account, if you have any professional account, business account like educational, just make sure you don't link it any Instagram or Facebook. This is not professional. Okay. Next, it is job description. When you describe your job, use bullet points instead of paragraph to make it easier. Recommendation and endorsement. Even me personally, when I see any account is have a lot of recommendation and endorsement, I feel this account is credible one. So make sure your supervisor or colleague endorse you online as well. Create custom URL. Okay, if you have recent experience on job session, so we're going to ask you about your LinkedIn profile. So if you have a custom one, it's going to look more professional rather than if it is the other one, the second one. Okay, after creating an account, let's give you a few tips to build your network. First one, connect with people you have never met in person. Even if it has cons, it opens a new opportunity for you. So make sure you be open for this new opportunity. Send invitations. I think everyone, that's what we are doing right now. We send an invitation for the program director, for the coordinator, for the resident. Just the more specific you become, the more you will get up in your network. Connecting. If someone sends you an invitation or request, accept it, go through his profile, see what is in common, and if you want to ask a question, just send him a message and ask a question. A status update. You don't want your account to be a dead one. The easiest way to do that, either to post a new post and ask questions, or you use engagement strategy. Me personally, I use that, just do like several times a day. Join a group. After you demonstrate your goal, you look for a small group or for a group to join. Just make sure the group is active, look for the group size, and it is relevant for your goal. The best way to do it, just search, use the keyword, go through the group list, go through the profile if it's a company, and join the group. Of course, when you are within the group, just become more specific, more professional. Just post a new relevant content. Do not post anything personally. Thank you. And from here, my colleague Duaa, she will take over.
Hello, you can keep this screen sharing, please. I have some technical error, so just keep your screen sharing and I will continue. Thank you, Noura. Okay, how are you, everyone? So we'll proceed. Give me 1 second. Okay. So here we have a group engagement process. It starts from contribute, then create, then follow and contact, and last you will become influencer. So we'll go through all this part in the further slides. So you can go to the next slide, please. All right, so create, we create post or we can comment on the group. So when we create post or a blog, so you have first the title should be less than 10 words and use a 2-sentence snippet test for a summary of an article or blog. So make sure when you share list, for example, an article, just write in a 2-sentence, what do you think, your ideas. So by this way, I know who are you and how you think. And then you can add a link for more information. So this is an example on post or blog that the first is, this is like example for a good title, real-time communication with Jive communities. And his this is 2 lines or sentence. He described what he think, and last you can end with what we call the CTA or call for action. So this is usually give a questions or request. So by this they can comment on your post. Okay, so this is how to create a discussion, and this is also an example. So next slide. Okay, this is all an examples. Then the process. So process, let's see, you join LinkedIn and you want to shine. So we'll start, let's say week 1, you will only contribute. So start joining groups that you are interested or in your field. Then at least comment on 3 to 5 discussions, ask questions or respond genuinely. This is week 1, only contribute. So I'm here. Then the week 2, start to create your own post. Start with 3 to 5 discussions, share industry news, any articles, and then you will receive comments on your whatever you share. So try to respond comments on as soon as possible, and connect after that. Connect people who reply for you. In week 3, you will repeat all this. Okay. Then you will become like influencer. You will comment on 3 to 5 discussion, start 3 to 5 discussion, respond to the comments as soon as possible, and connect with the one who reply for you. So this is process in practice. So next slide. Then how to search for job. Okay, so here we have, let's see, this is a company. You search in the top, you find the job search. So you write the companies, any company you are interested in, okay, or hospital or anything, and then you will go for the career of this company, and you will find out what they have available positions, and you can have an overview and read about the company. So this is how you can look for the job, that like instead of just that like suggested jobs, you can go for the interested company by search and the job research and write the name of company, and in the career you will find all the available positions. Okay, and we have also okay, you can go to the next slide, the key to success. Okay, so so the key to success to make this networking a habit, because if you just like do it and stop, so you will not update it with the new positions that they come like within 24 hours, within 48 hours. So it isn't what you know, it's who you are, who you know. So add how we add we make connections. We add our co-workers, friends, families. We add a group members or social media contact. So by this way you expand your connection and personalize it. Okay, this is how to send a letter or so invitation. This is an example. You start with greeting with their name, and then where you know him or her from, and why you want to connect, and then closing with your regards and name. This is how you send an invitation to connect on LinkedIn. Okay, and there is other thing. It's called tags. You can organize your connection. by going to tags, and you will find, you can, lately we have like 500 connections. So you can organize it with friends, co-workers, or like professors, MD, okay? It depends. So you can organize by this way. It will be easier if you would like to connect or send email or letters. And you can find in the connection, it's you can search with last name or companies or locations. And then here it's how to add like in your profile URL to, if you have any like Twitter or any social media account, you want to add it as link or business card, if you have, or email signatures, you can add it to your profile at this way. That's URL, okay? And then what it's advised here to just make it a routine, like participate daily on LinkedIn, like 15 minutes every morning, make it as habit to 15 minutes, clear your inbox, add people you met in the last 24 hours you are interested to connect, and status updates, and check the groups. So it's just a 15 minutes, like a routine. Then okay, so the last advice, like what is the secret of being successful at using social media to create my brand or like shine in LinkedIn, to be consistent, engage with what it's like, make what we previously mentioned, to create, to discuss, contribute, and then we create discussions, 3 to 5 discussions, and reply as soon as possible, and then connect with who is reply, and last we become influencer. And that's all for today. Thank you. Appreciate it.
Thank you so much, Dr. Doaa. Thank you so much, Dr. Noura. Such an informative presentation about the LinkedIn. The question for all the fellows, any question, any inquiries about the LinkedIn? Nothing in the chat, no questions. We can go for our next agenda. We're going to talk about Twitter presenter. It will be presented by Dr. Majed Mohammad and Dr. Bashayer Mohammed. Dr. Majed, you can start if you're ready.
Hello, everyone.
Hello, Dr. Majed.
My name is Majed Mohammad. Today, Dr. Bashayer Mohammed and I are gonna have a brief presentation about Twitter for those who are not familiar with Twitter or the non-frequent user of Twitter. So this presentation is intended for those new to Twitter and for the beginners to get up to speed with Twitter's basic functionality. So what is Twitter? Twitter is a social networking and microblogging service. It allows you to send and view short text-based posts called tweets. You can follow others or can be followed. So what do you use Twitter for? You can use Twitter for learning about what's happening. You can use it also for keeping in touch with friends. You can use it to follow the famous and the not so famous persons. You can also use it to learn about breaking news and to conduct searches on real-time posts. Also, you can reach a target audience and you can have your audience talk back to you. So how do you use Twitter? You can go to twitter.com via a web browser, and there are some specialized software with advanced features, for example, TweetDeck, that can offer enhanced functionality and incorporate more of what you can see on Twitter.com. You can see features like a full tweet composer, advanced search features, and new column types. You can tweet via SMS text messaging, and there are specialized apps for tablets and mobile phones. So who uses Twitter? It's basically everyday people, and it has been reported that there are 300 million registered users. News media and celebrities and activists and politicians, organizations like universities, all of them use Twitter. So the question is, what are the benefits of Twitter in higher education? First, it provides fast, to-the-point communications. Second, it can provide you with on-the-go messaging, which means like you can text while moving around and doing other things. It also can provide you with highly adaptable. It is highly adaptable for both computer and mobile use, and the ability to create RSS feeds, and the retweeting helps spread the word. So let's go through some Twitter terminology. So the tweets mean like posting made through a Twitter. It could be up to 140 characters in length, and tweets often include shortened links to other websites. The @ symbol is used when you are referring to a Twitter user by their account name, like in the example here. The hashtag symbol is in conjunction with the keyword to make your post easily searchable by the public. The retweets is to repost someone else's posting with proper attribution, and this is a good way to spread the word. A retweet is typically indicated by preceding the message with the retweet at username. The direct message option is by default, like basically any message you post via Twitter are publicly searchable. However, you can send a direct or private message to someone using the direct message function. And from now, I'm gonna let my colleague take over the rest of the presentation.
Hi, hello everyone. Can you hear me?
Yes, Dr. Bashayer, go ahead. You can hear you.
Okay. To get started with Twitter, there are many tools to access Twitter. So like the phone app, we can use Twitter phone app that can be downloaded on our phones from the App Store. But to keep things consistent, we are using twitter.com interface here. So we are going to start with creating an account. And to do so, we're going to need an email address and to choose a username and a password. Then we're going to press the sign up. After that, the Twitter will check the username availability and the password security. And if there's any other account using the same email, because we cannot use the same email address to create more than one account. Then we're gonna press on create my account. And to log in, we're just gonna need to use the username and the email address to access the account. The Twitter will display the main screen. The main screen consists of the timeline. And the timeline is a real-time stream of tweets where you see all the tweets shared by your friends and other people you follow. And also, you can also tweet by typing in the what's happening space. You can tweet or share your own tweets from here. If we want to search about something or about a hashtag, we can conduct a hashtag search. And by a hashtag, we mean a word or a phrase preceded by a hash sign used on social media websites and applications to identify digital content on a specific topic. We will type the hashtag here. And then the screen will display all the tweets related to the specific hashtag we are searching about. Each tweet has 3 options like favorite, retweet, and reply. If we press on retweet, we will be retweeting the tweet that is repost. We will be reposting or forward a message posted by other users. And we have the following and the followers. When you press on following, it will display the list of people you follow. And when we press on the followers, it will display the list of people that follow us. And we can choose people we follow by press on who to follow here. And also Twitter can give us suggestions of people to follow. And if you have someone specific, we can search someone's name in the search box, and then we can start follow him by pressing the follow button. Here in the following, we can see who are we following, and here the followers list. And that's pretty much it about Twitter. Thank you all for listening. If you have any questions, I'll be more than happy to answer. Thank you.
Thank you so much, Dr. Bashayer. Thank you so much, Dr. Majed. Any question for Dr. Bashayer or Dr. Majed?
Thank you so much, everyone, and thank you for the great presentation, everyone. These excellent good presentations, all of them. Thank you. Can I ask all the fellows, can you just raise your hand or click on the hand? Show me who use Twitter. Just like a quick call, see who has a Twitter account. Excellent. So can some of you guys who has a Twitter add more comments about your experience with this? How do you think it's beneficial for you for this season of the application? Do you think it's going to be of value? What and how can we use it so that it may apply positively for other fellows to create an account and use it the way you want to use it, if you have an idea about it, or if you have someone in the past who used it and got some positions or some interviews. Can you share? Thank you so much.
Thank you, Dr. Nader. I had it recently, but honestly, still I'm just contacting people. I'm trying to see who they're in our to help or to be like in the same specialty or something like that, because I hear that from our coach Sarah. She has benefited so much about that, and she came to know more information about the application, about the programs, and she get like connected with other people, get matched before, and she said that was a very great experience with her.
Excellent. Yeah, thank you so much for sharing that. So Sarah, she was very active using Twitter, and she also contributed to some tweets when she submitted, let's say, an abstract that has been accepted, or an abstract that she presented, or programs that interested in. So all this will get some viewers, and then maybe you will have some people who are interested in your work. And at the same time, if you apply to their program, maybe they can look at your Twitter, so your information, your application. So it's just created more opportunity of networking. Excellent. Thanks for sharing. Anyone else wants to share? Go ahead.
Hi, Dr. Nadir. So on Twitter, most of the virtual open houses, they post their virtual open houses. So we just had to register to the Zoom link. So once we register to the Zoom link, they will save our names in their Google Forms. So it's a good opportunity for them to show our interest. And while you're sending a letter of interest to them for any particular university, you can use the same email, same Zoom link registration email, and ask them, hey, saying that, hey, I'm interested in this program. I also attend this virtual open house. So that will show like very genuine interest to get an interview opportunity.
Excellent. Yeah, thank you so much for sharing. Yeah, this is also important. Thanks. Anyone else? Go ahead. We hear.
Hello, Dr. Nadir.
Hello.
I think Twitter gives an opportunity to networking. when you have certain followers and when you get a lot of feeds, Twitter automatically rectify your level, your networks, and they provide more related tweets or more related feedback according to your followers and according to your retweets or tweets you have posted. So, for example, I've been doing a lot of networking and uh, through the Twitter and tweeting about COVID, long COVID, and I can also put my username here in a comment section, and if anybody was interested to see. So now I get a lot of feedbacks related COVID, long COVID, their researches. There are a group which are dedicated about the long COVID thing and Europe section in that media. They have recently done some researches and they are actually proposing some guidelines about long COVID in UK healthcare season. So it is good to get those kind of news information. It is just plenty of knowledge, and I think that's very helpful.
Excellent. Thank you so much for sharing, Meher. This is also excellent points. Thanks.
Thank you.
Yeah. So you can, as Meher mentioned, when you put some new tweets, if it's a specific, some people might be interested in that specific area, and then you can start your networking that way as well. Excellent. Anyone else? How about LinkedIn? LinkedIn. Anyone use that and maybe you found it helpful?
Me too, but still beginner also. Go ahead, Monica.
So about LinkedIn, how I approach people is I attend conferences and I also read about articles and then post the articles. My favorite is going to the conferences and meeting people. And also my hobby is taking pictures, whatever I see. So I just take pictures of all the faculty members, and I also just post on LinkedIn and say in the post what's the conference is about and what are the take-home points, what I learned. And I also thank the opportunity for creating the opportunity to have whoever I met, even I know, or even if I don't know the person. And then I will just post on LinkedIn. And then through the post, whoever sees my post, I will get a notification that the person X viewed your profile. And then I will connect to that person and saying that, hi, nice to meet you. And then I will just start my conversation saying that this is so-and-so, I'm applying for this specialty. And do you have any recommendations for me to, proceed in the career? So.
Sure. Sounds good. Excellent. Thank you so much for sharing. Yeah, it's important to, go ahead. Sorry.
Okay, thank you so much. Go ahead, Dr. Nal.
No, I just want to comment on that. It's a great opportunity as well. So thanks for sharing.
Yes, so much. That's very great, Monica. Thank you so much. If no question here, we're going to the last agenda for today.
Let me, before we
okay.
can I just share here? I don't see Ina with us here, but this is our Twitter account. You can see that. Here. So basically, this is Ina's website, and she tweets also about her. As I mentioned, she attended or presented in one of the conference and Alzheimer's disease association. It's an international conference. So she got some of the feedback, and she also now I think joining another fellowship in Florida Mayo Clinic. So that also can help advertising her application. So just I want to share with you. If she is here, maybe she can give us a. I don't see her. Yeah, so basically you can advertise what you are doing, especially if it's a small things or conferences or papers, manuscript. Let's say if some of you submitted something, so you can put it, or we submitted this, or where we got accepted for this conference, or this is our project. Anything that you want to shine in your application might be, and it's a good opportunity to share with others. So at least you have some connection, some networking there. Thank you.
Thank you, Dr. Nader. That's very helpful. Thank you so much. By this time, we're going to a research study, informed consent, to be presented by Dr. Amir Abdurrahman. So, Dr. Amir, if you are here, I can try to share your screens here.
Yes, I'm sorry, I have some technical problem.
Okay, let me try to share it. Yeah. A second.
Yes, so you can hear me?
Yeah, we can hear you. Sorry, it was muted.
Okay, so we're gonna talk today about informed consent. So the first thing, why this topic is important for us. This is the most important thing, and this is because of the obligation to be truthful, and engender the patient trust, to own the patient trust, and to develop patient autonomy and the integrity of the profession. This is the most important things that why this topic is important for us. And we will talk next about the origin of the informed consent, which is the third one. Yes. The origin of the informed consent and prospective, which is the first thing. We have the beneficence, which is obligation to maximize the benefits and minimize the harm. This is the meaning of the beneficence. And then the non-malfeasance, which is decreasing the premium, non necessarily, I hope I pronounce it right, or deliberation of the harm. And the third one is the justice, and equals should be treated equally, and autonomy, which is the self-governance. And then let's start by the beneficence. The beneficence for the physician must have the best interest of the patient in mind and minimally influenced by other concerns. So I'm looking at for the benefit of the patient. And for the patient, must trust that the physician, their advocate and agents. So the patient should also trust the physician, their advocate and their agents. The non-malfeasance for the patient, for the physician, sorry, must not intentionally harm or disadvantage the patient. This is the non-malfeasance. As we said, it's do no harm, right? We don't want to hurt the patient. And at the same time, for the patient, must trust that the patient will not willingly harm. This is the meaning of the non-malfeasance. The third one we have after the beneficence and the non-malfeasance is the justice, which is prohibition against denying benefits, just like capriciously and by selective criteria, and then the obligation not to selectively burden. This is the justice, which is I think it's obvious. And then the fourth one, it's the autonomy. The autonomy, the patient's self-governance, being one's own person without constraint by either another's action or psychological or physical limitation. Okay, this is the autonomy. So we will move to the standards of ophthalmology and AAO Code of Ethics, which is the ENT, American Associate of ENT. The informed consent, they said the performance of medical or surgical procedure shall be preceded by appropriate informed consent. Okay, so when obtaining informed consent, the medical facts and the recommendation consist of a good medical practice must be present in understandable terms. That means we have to make it as simple as we can in order for the patient to understand the procedure. Okay, to the patient and to the person that's responsible for the patient. Such information include alternative modes of treatment, if there is another treatment modalities, the objective of the procedure that we are going to do it, the risk and the possible complication or treatment, and the consequence of no treatment. So if the patient is not going to do this procedure, what's gonna happen? And if he's gonna do it, what's the benefit from it and what's the risk from it? The operating ophthalmologist must personally confirm with the patient or the patient surrogates his or her comprehension of this information. So the operator, which is the surgeon, he is the one who's responsible to give all those information to the patient or the patient surrogate. The next thing, we have the research and innovation. The research is conducted to provide information on which to base a diagnostic. Appropriate informed consent for the research innovative procedure must recognize their special nature and ramification. It's just like the procedure also. If we are including the patient in research. And then we have standard of ophthalmology, International Council of Ophthalmology. Standard 1 and 2 obtained on the informed consent from the patient for all intervention. Whenever we have intervention, we have to obtain the informed consent from the patient. And the 5.2 standard inform research subject of the nature of the investigation and obtain full informed written consent. I think, as I remember, there is two types of informed consent there, and there is a written one. So here we have to do a full informed written consent. And then after that, we have the principles. The principles of informed consent. Informed consent is a dialogue including an assessment of the patient competence to decide. So we have to know that does the patient has decision-making capacity or not? Is he competent to make his decision? Disclose the relevant information and assessment of the patient comprehension. Affirmatively obtain consent from the patient or surrogate. Informed consent occur before a patient or surrogate sign anything. So we have to describe all of the stuff. So it's as they said, it's not only a signature. It's not only a signature. We have to go over the risk, the benefit for getting the procedure or refusing the procedure. And then we have the practical informed consent disclosure. The reasonable person standard. What is the reasonable person would want or need to know? Okay, and then after that, the nature of the procedure and the indication, as we said earlier, the expected benefits, the advantage, the possible risk and disadvantage, and also we have the reasonable alternative, including observation. What we like the alternative treatments that we could do it in order to, let's say, avoid this procedure. And then we have the practical informed consent documentation. The first thing, we have the rationale. why the treatment is purposed. We have to describe to the patient why we are doing this procedure or why you are included in this research. And the second thing, we have the benefits, the advantage of this treatment, and the risk and the complication, which is potentially adverse effect if everything goes right or if something goes wrong. We have to also include this in our informed consent. And also, as we mentioned earlier, the alternative treatment that we could do instead of this procedure. Then we will move to the practical informed consent in a special situation. We have, it's not only, as we said, it's not only for the procedures. We also use this during the research, especially the interventional one, the randomized control trials. The clinical research, the patient have the right to know they are a subject and include the retrospective review. Or if we are using off-label drugs or devices that it's not approved to treat or to use in a certain situation. Surgical co-treatment. Patients have the right to know and affirmatively consent to the treatment by other providers. And then we have the misleading advertising, which might invalidate the informed consent. I think this is the end of our presentation. Please feel free to ask any question.
Thank you, Dr. Amir. It's a very great presentation. Anybody have a question for Dr. Amir?
Again, thank you so much for all the presenters, and thanks, Amir, for this the consent information. So I use that during residency. You're gonna be required to do some procedures, let's say lumbar puncture or arterial blood gas or any other procedures, let's say nasal tube insertion. So you need to document that you spoke to the patient or the decision maker about the procedure, and then you explain things as far as just mentioned, the benefit, the risk, and the complications that might happen. And if they agree, they sign, and you can go ahead. Sometimes you are required to have a witness for the procedure and the documentation of this. Like in my case, I usually ask the nurse to come with me and explain things to the patient. In nursing homes, we don't have a lot of procedures like at the hospital. So most of my stuff is about arthritis. So I give options for injections like steroid injection in the joint, shoulders, knees, hips. So I have my own form. If I can find it, just a second. So I have this form. It's for joint injection. I copy paste the patient information. This is just a made up name and the date of birth and the location of my patient. And I put the date for the procedure. And this will put it in a format that the computer will display it in a good presentable, printable form. And then the date of the procedure, I can change that also to say date of the procedure, for example, and it will have this displayed. Forget the yeah. And then I explain things like what the name of the procedures, why we need that procedure. Let's say the patient complain of the left shoulder. So we tried the oral medication on over-the-counter opioid. Everything didn't work for them, local, topical. So the last thing we want to do is, for example, in my case, is right shoulder steroid injection. So I explained to the patient that this is the indication, this is your condition, and then this is the benefit that you will get out of this procedure. We know it may benefit patient with arthritis, 50% will benefit from it, 50 kind of maybe, and how long it will last. Like some of the patient will take care of the symptoms forever. Some might benefit for 6 months or so, and they may need a repetition of the injection again. Sometimes it may not work. And then what are the risks involved? So if there is a chance of bleeding, chance of infection, chance of other problems that you want to discuss. And if they agree, then you can print that. So in my case, I will just highlight this, I go to print, and it will be just the selected area. This is the form where I will print it. The patient will sign, put their names, and the nurse will sign as well. I use this not frequently, but I offer my patients some of the options, including this one, if they fail other like oral medication or topical medication for their symptoms. And this can be done for any other procedures. That's as far as clinical. As far as research, you have to also do the same. So you will advertise for your research project or experience, and you will get the volunteers. The first thing they do is you want to inform them about what the methods that you are going to do with them. So you want to explain what the experience of the project about, what the goal, what the benefit, and what risk that also might entail or may contain. So you want to explain everything to them and make sure they understand, they can repeat what you said to them, and finally they can sign the consent. And then you can proceed to the next step. If it's randomized, then you put their name on the thing that so they can be randomized either to the control group or to the active group, let's say medication or some other method intervention. So this is how you do the. So go ahead, Amir.
I have a question. Is it the informed consent? It could be conducted in the observational studies. It's only in the randomized control trial, or also in the observational studies like the cross-sectional or.
So it depends on how you want to do that. So if you are involving the patient, you have to get the involvement of that patient. If you are getting a whole group, let's say just what we call it secondary data. If the data is primary, you want to get the patient involved and you can get information from our patient, then you have to inform them. Let's say you are fellows now online. I want to do questionnaire about how you do with Twitter or something and how this will benefit you. So I have to put this consent online for you before you put your information, before you answer any of my questions, because there is a risk when you put your information. Let's say you put your email. So I can use your emails and sell them to a company, then they will contact you to sell their product or something. So this is a risk for you. I have to explain that I will get your information, but I will save it in a secure, whatever. So if I'm gonna use it, I will tell you what exactly I'm gonna use. If I use it differently, then I'm in legal problem. And then before all this happens, I want to get an approval by the IRB. So the IRB will ask me, where is the consent form before I submit to you my questionnaire. So I have to get an approval. So one of the steps in the approval is how do you explain things to the participant and what risks are involved. even if it's just information that we are collecting, like just about Twitter use or something like that.
Okay.
So if that makes sense. I started like a few years ago with a project about how can I use videos, let's say YouTube videos, to educate patient about smoking. So I just show the patient the video, let's say a 2-minute video, and then I will ask them questions. What do you think about this? Do you think it's going to be helpful? And so forth. So let's say 5 questions. Although there is no high risk or absolutely like tangible risk for them, I just watch, they watch the video for 2 minutes and then they answer my questions. But still, if my questions, one of them will be identifiable information. Let's say I'm asking about their age, date of birth, name, or something related to them, then I have to show them the whole consent. So they will be informed and they will agree to give me the participate and give me their answers. And I will save their answers and I will do the analysis. Then I will present them as a collected information. So it's very important in the research, as you said. Thank you.
Thank you, Dr. Mohammed.
You're welcome. Anyone else? Any questions? So the IRB procedure is very important in any projects that involve humans. You have to go through that. So you have an idea about the project, you put the idea, you want to get some funding for the idea there. So you put all this together. You cannot start unless you get an approval. Here at MSU, we have a body that's a review board. And then at the hospital, let's say we have patients at Spare Hospital, they have their own IRB also, the board there. And the good news is they talk to each other. So when I did with the fellows the first time, the first batch, we collected some information, but before we go that step, we wrote about the project and then we wrote our IRB approval application. So we send that to them. So we send it to MSU and we send a copy to Spare. But because they work together, if one of them approved, then automatically it will be approved by the other. And there are methods to get that approval quick. It's like a fast one if there is no identifiable information. So what we did, we collected information from the EMR collectively. So how many patients with heart failure? So they say in last year, there are, let's say 60. So they will put 60 in the database for us, but we don't have information as far as to go the next step to identify which one. The IT, they can do that for us, but we cannot go to the system. So we put that in the application that we will collect information. The IT will give us the description of what information we want. Heart failure, hypertension, diabetes, let's say these are the variables that we want, and COVID. So 4 variables, we put them for the IRB approval. And when they say that, when they see that we are not collecting information that can be identified so that the patient can be identified, they will say, okay, it's a fast approval procedure. But if you want to collect information, let's say the same information, but we want to know the patient demographic, date and date of birth, gender, socioeconomic status, and the information like name and so forth. All this can be used, but it's the risk for the patient. If we put it in a file and that we get hacked, then this information can be used by a third party or some other companies to solicit or sell some products to these patients. We don't want that. So if we are going to collect this information, we put this information in the application to the IRB. When they look at this, they will ask us what the consent form. So we need to have a consent form in that form, we will say, okay, we will collect all this information, we'll save it in a secured file database, and then this file will be accessed only by, let's say, Nadir, Amir, and Sulafa, let's say. These are the ones who have access to this file, no one else. If that's approved, then we are the responsible parties for this information the whole time. And then we will answer the question is, what do we do with this information after we are done with the, let's say, analysis and publication and everything? So we say we will save it for 2 or 3 years, and then we discard this information. So this file will be destroyed, deleted forever. So this is how we explain this to the IRB approver, the board. So when they approve, it will be processed the same way we just mentioned. So the patient will be like they will give them the form, they explain the things, and then if they agree, we collect the information. If we don't, we will have problems. If they don't agree, then they will not be included, if that makes sense. For the past, if it's a retrospective, you will also get some approval, but you don't need to identify the patients. So you will collect the information as collectively. So 30 patients with diabetes, 25 smokers, something like that. So from the data, you cannot go back and say, oh, I can go to the chart and find out which patient, because you don't have this information in details, if that makes sense.
Yes, thank you so much, Dr. Nader. It makes sense, really. That's very informative.
Thank you.
Thank you so much. Okay, by this research study, we did finish our agenda for today. Our Orange team. So if any question about any topic, any inquiry, feel free to ask.
I'd like to thank all the presenters. These presentations were very, very good. And thank you so much for hosting this Zoom meeting. But let's go over the projects, the current projects. If any one of you wants to update us or give us some questions or feedback or anything about your involvement. Thank you.
Hi, Dr. Nader. This is Rada. Can you hear me?
Yes, doctor, go ahead.
All right, this is Ragda. So regarding our project, the utilization of YouTube as an educational tool during the pandemics, we finished extracting the data and we just started on the data analysis. We go into use the Google Sheets quick analysis for that. Dr. Asman, I believe he sent you the documents, but he said you didn't get back to him yet.
Sorry, which project was that? Sorry, I didn't.
Utilization of YouTube as an educational tool during the pandemic.
So he sent me? Okay, I will check my email then.
Yeah, he said he sent you the Google Sheets with all the data extracted from the video, the 165 video. I excluded the video that wasn't in English, so we end up having like 145 videos. And as I mentioned, I am going through the stuff again so I can have the variable written in a good way. So when I do the analysis in Histogram, it will be there and I can like interpret the data in a really easier way.
Sounds good. So I will look at his email and the data and I will get back to you guys.
All right. Thank you, Dr. Nader.
Thank you, Laura. Excellent. Anyone else who wants to share? I know Akila sent me a file so that I will review for submission. I think she already and her team submitted the abstract, or they're working on that abstract, but the manuscript, I need to review that. So I have 2 items in my agenda. Anything else? I know Mahir and his team are working on the long COVID. And I need to get some of the fellows. I know the past few weeks or days were hectic for all of you during the application, finishing the app and the ERAS application and so forth. But I think now it's time to work hard on the project. So any updates
Yes,
here or
Nader.
Yes.
We are enrolled with Dr. Batram with two topics, two projects. The one is methylene blue with Alzheimer's disease. So just like they are making the Google sheet now, and they're going on that. Hopefully they will we will go actively on that project.
Excellent, excellent.
Thank you.
That's good. Perfect. So I think there are some fellows who are not involved in some of the projects. So can I just share with you this together if someone can help me? So this is a table. I think we shared this document with all of you. If you don't have the access to the document, just this is the current, shoot me an email. So some of them submitted, some of them accepted, and we're gonna present. I think in the coming days, some recent ones, and then we are working on new ones. So this is the webinars we already did in Arabic and English. This one is new, what's the incident of medical device related. So Dr. Talal is working on that. And this one is submitted. COVID pancreatic disease also submitted. We are working on the pancreas. So Amy and her team supposed to be working on the manuscript. So if one of the team can also work with Amy as far as finishing the draft for the manuscript and let me know, we can work on finishing that project also. The disease of Alzheimer's, that's also done or submitted. Effective vitamin D submitted. All right. Anyone wants to update us? These are already done in the Alzheimer's, I think, conference. So the dental group are working on this. So if they are able to update and let us know what the progress there. We are working on some different kind of applications or the use of this. So if these groups are working, please update me. There are 3 groups or teams. Let me know. I know we need to meet to work on some of the details of the app itself, how to.
Yes, Dr. Bashayer, maybe she has something.
Okay, go ahead, Dr. Bashayer.
Yes, Dr. Nader, how are you?
Good, thanks. How are you?
I'm good. We are working, me and my team, on the project of Ixaban versus low molecular weight heparin for treatment of thromboembolic disease. We are writing now the manuscript. Actually, we're done, except for the discussion part. We will be submitting the research next week, inshallah. I'm gonna send the manuscript for you, inshallah, in the email to revise it for us, inshallah.
Inshallah. Sounds good. Thank you so much for update and good luck.
Thank you.
Excellent, excellent
Thank
work. Yeah. So there are 2 other people wants to go ahead.
Yes. Says Adil.
Yes. Assalamu alaikum, Dr. Nader. We are in the final preparation of our abstract. It's traditional review. We finish like almost all of it. We are in the step of just paraphrasing and rephrasing and plagiarism check. And after we're done, I will send for you a copy. But now, because I'm so busy with the ERAS, so I stopped a little bit.
Excellent.
Thank you. Thank
Excellent.
you.
Thank you for that update, Shana. Thank you so much. Go ahead, Amal.
Assalamu alaikum, Dr. Nader.
Alaikum salam.
So we submitted our abstract, the effects of anesthesiology on post-operative cognitive dysfunction, to the Frontiers in Medicine journal and also to the American Academy of Neurology, and we are waiting acceptance from both.
Excellent.
Thank you so much.
You're welcome. That's very good. Excellent. And I wish you good talk. Good luck. All the best.
Thank you.
Thank you. Anyone else have any questions or any comments?
Dr. Nadir, I have to catch up on the INR app.
Yes,
So it's going slow. I need to catch up because of this application. So
yes,
in the next few weeks, I will give you an update.
Sounds good. Thank you so much. I appreciate it.
Hello, Dr. Nader.
Hello, Nafisa, go ahead.
Okay, I would like to. Sorry for that.
No, that's all right.
Okay, I'll fix it later. Okay, thank you. I just want to update that on the other case report, insight into early psychiatric manifestation of Parkinson's disease. A case report of Parkinson's disease presented with anxiety. So we already finished that, and I'll send you the case in order just to review it and let me know any suggestion about it. Okay.
Sounds good. Thank you so much. Yeah.
Welcome. Thank you.
Excellent. Good luck. Perfect. Okay. Anyone else?
And this me. Hi.
Hi.
So for the other project that's we're working at, the CBD and treatment of chronic pain in palliative health, we're still collecting the data. We can't disclose because everyone was busy with the ERAS applications. We just, as I told you, we're doing 10 years from 2012 to 2022, all the literature review from that years. We almost finished collecting the literatures, the articles.
Excellent.
Thank you.
That's very good. That's very good. Excellent. Good work. So if you have any other comments or updates, please jump in. I'm going to share for the next week agenda. So the next team, if you can look at that, this agenda, and let me know if you have any questions. These names I put, as I said in the past, just randomly from the list I have. If you are interested, if you have time, go ahead, confirm with your team leader. If you have any obligations, otherwise you are busy doing other stuff, traveling or family issues, please also let your leader know so that someone else from the team or from other team might participate in preparing for next week agenda. Thank you so much. All right. Yeah, go ahead.
Thank you so much. I would like to thank you very much. You are very helpful for us, for all of us. And I wish good luck for everybody applying for the residency. And I want also to thank my team. They did great work today. Thank you so much and good luck for all. Thank you.
Thank you so much, Dr. Khalid, for moderating this Zoom meeting. That's great. I really appreciate it. Thank you, everyone, presenters and attendants, and those who will come later to see the recording. I wish you all the best. Good luck. Have a wonderful day, time, night, or evening, wherever you are. Assalamu alaikum. See you next week.
Thank you, Dr. Nader.
Thank you.
Have a good day. Thank you so much.
Assalamu alaikum.
Thank you, Dr.
Thank you.
Thank you, Dr. Nader.
Thank you.
Thank you, everyone.
Thank you, Dr. Nader.
Thank you so much.
Have a great
Thank
day.
you. Have a wonderful one.
Thank you, Dr. Nader.
Thank you. Mahir, have a wonderful
Thank you,
one.
Dr. Nader.
Thank you so much.
Salam alaikum, Dr. Nader.
Alaikum salam wa rahmatullahi. How are you?
Fine, how are you?
Very good. Thank you.
Yeah, I'm sorry, I have a very quick question, please.
Yes, please.
Yeah, so for the presentation, that should be done like the next, we should submit the abstract in October. So just
Which one? Remind me which one.
yeah.
We have
So
three, I
like
think. We have to.
yeah,
Mm.
creating a unique virtual training
Oh yeah,
experience
yeah,
for
yeah,
a
yeah.
match.
Yeah, okay, yeah. In
This one,
November.
yeah.
Yes.
Yeah, in November. So I think we should submit our abstracts in October, or correct me if I'm wrong.
Yeah, I think October 10th, I think. Yes. So we need to make sure all the people involved, like the authors, and I just want to make sure we have at least a draft for the poster. If you can create that with the team, and then submit it, and I'll just make some changes if needed. So I will print that, and I will go to the conference. So if anyone interested, they can also attend that meeting. It might be helpful. If not, when available, that's also not a big problem.
Okay, that's great. And just because we will start, me, Avinash, and the other group will start on creating the draft for the poster. It will be helpful if you have the last year one, so we can take a look.
So I will send you that. So that you can just modify whatever you think we can add from your perspective as fellows, because I created that just with other group from first batch. So your group will look at it like through 2 years. Now we are in our third year. So see how that can be. The idea is to inform attendants in the conference room that if they want to replicate this to other institutes, how they can do that. So if we can look at our poster and make it look like something that can be replicated, the idea.
Yeah. And do we need to create also like PowerPoint oral presentation, or the poster is
just one poster?
Okay. Yeah, so we'll start working in that.
Sounds good. So I will send you the draft, I think, or the PowerPoint, or maybe Google Slides, something. I will send it to you.
Okay, thank you. Yeah, just to give us guidance or what should do.
Sounds good.
Thank you so much.
Thank you so much, Salah, for the update.
Okay,
Yeah,
okay, thank you. You too. Bye. Thanks.
Bye. Have a good one.
Okay, you too. Bye.
Salam.
Thank you, Dr. Majed.
Thank you so much. Have a wonderful day. Good night.